Hello from Indiana Hospital Association. My name is Rebecca Hancock, and we are practicing on sepsis this month. And this is Sepsis Awareness Month, the month of September. And we are providing content for clinicians and communities on how to improve care for the patient with sepsis. This afternoon, we have Dr. Raymond Lee Kiser with us. And Dr. Kiser has been quite the champion for sepsis in the state. He's a nephrologist and the Hospitalist medical director at Columbus Regional Hospital and the former chief of staff. He has tackled clinical care challenges in the hospital and consulted with different hospitals on strategies to overcome the type of difficulties that they were having with the sepsis bundles. Columbus has been quite the champion. We're very thankful for their outreach and consultation and sepsis leadership. The sepsis coordinator, Chris Newkirk, has been integrally helpful in a sepsis work group in the state, but it's this unique leadership role with sepsis as the nephrologist that Dr. Kiser is that provides a different lens with which to care for the patient. Columbus's sepsis compliance for the bundle is above the national average, so they are leading in the state. And we're very appreciative of what he's going to share with us today. And some of the essentials for clinicians that he's going to talk about are screening efforts in the emergency department, the fluid bolus, the notorious fluid bolus, antibiotic stewardship, and the measurement of lactate. Dr. Kiser, welcome to our podcast today.
Rebecca, thank you so much. I appreciate that. And thank you for giving me some time to discuss some of these issues that we're all dealing with as we address sepsis. One of the first things I did want to discuss was the issue about screening. I hear from a lot of physicians that at times, depending on where they work, that they feel like either we're screening everybody for sepsis or on the flip side, sometimes we're not screening enough. And I like to, let providers know that I really feel like we should think about screening very similar to how we thought about looking at acute MI really several years ago. There was a time when patients didn't get diagnosed properly with myocardial infarction, and we found that we really just had very high mortality with that. We realized that there was this golden hour, so to speak, with myocardial infarction that you really needed to try to intervene quickly with these patients. And so, over the last couple of decades, we actually have gotten much, much better at screening. Instead of just thinking of somebody who comes in with chest pain radiating down their left arm, we really look at much more broad symptoms, symptoms that would typically be kind of atypical. In addition to that, we've actually developed better screening tools. We, of course, always use the EKG, but with acute MI, we've kind of moved in a spectrum from using CPK to CKMB, and now to a more specific test, troponin. And so with that, what I think we've done is gotten much better at diagnosing myocardial infarction. Very similar to that, we're in these stages of sepsis. So I think within the last 10 years, we've gotten much better, at least in some institutions, about casting a very wide net to try to make sure we are screening everybody with sepsis. And that is one of the issues, is when you try to have a test or tests that are 100% sensitive, that means by nature you will not be specific. And what that means is you will absolutely screen people and it will look like they have sepsis, but they don't, so you're getting a false positive. And what I always tell folks is at this point, because sepsis has such a high mortality, I still believe it is very important to cast that wide net, especially in the emergency department, which is really where most institutions find that the majority of their septic patients will present. So I still recommend a very wide screening tool. And at this point, I honestly still believe that the SIRS criteria is probably the net that we need to be casting for that. There is definitely some debate as far as what is the best screening tool. And I do believe that with time, we will get even better. There are now some electronic health records that will use the SIRS tool as the initial screening, but they will also try to incorporate more patient-specific items. And I think as we get to that point in time, we will get even better at being able to have a very large sensitivity, and hopefully our specificity will improve also. So at this time, my recommendation is still that we use the SIRS criteria or kind of a SIRS plus criteria for screening in the emergency department, that we cast a very broad net. We try to make sure we're thinking of, honestly, almost every patient who comes in, at least think about whether or not they may have sepsis. I think it's probably best done, honestly, if it's done by the electronic medical record, so that it works in the background and then sends a note to the provider to say, have you thought about, this patient who could potentially have sepsis? The biggest thing I always tell folks when you're using the SIRS criteria is always remember the diagnosis of sepsis hinges on you thinking about them either having a known infection or a possible infection, because there are other things that can obviously cause positive SIRS criteria. The ones that we run into most common would be something like atrial fibrillation. You get a rapid heart rate, you may get a drop in blood pressure, you may get somebody who's tachypnic, but if there's no indication of infection, then they absolutely don't have sepsis. The caveat, of course, being, for example, atrial fibrillation, one of the causes of it may be sepsis. So, you really do have to think about things like that pretty carefully. But as far as screening, again, I'm still a proponent of having a very broad net using the SIRS criteria. I think it works best if it's automated and then sends a signal to the provider to at least get them thinking about sepsis as a possibility. So that's really one of the big things that, I would emphasize for screening. One of the other big things when we're talking about screening that is incorporated into that often is a serum lactate. And that's another thing that I really hear a lot of debate about among providers is the lactate really useful? Obviously, there are other things that can cause an elevated lactate, and I absolutely agree with that. And again, I usually try to talk to providers about things to think about if your lactate is elevated. So a lot of times we will obtain that level as part of our screening for somebody with sepsis, and it will be elevated. And once again, an elevated lactate does not mean the patient has sepsis. It does mean you should consider sepsis in that differential diagnosis, but there is, in fact, a differential diagnosis. And so I try to go through that with the providers to help them understand what are some other causes. If you really don't think the patient has an infection, what should you be looking for? And the mnemonic that I like to use is actually lactates. The L in that would stand for liver and lung disease. So certainly somebody with very advanced cirrhosis may have an elevated lactate because they're not able to process the lactate appropriately. Likewise, those with lung disease can actually have a very accelerated lactate just because they're producing so much. And those are generally patients with a severe COPD exacerbation, not just mild COPD or COPD at its baseline. Other things would definitely be anaerobic metabolism. Now, we could think about that as somebody like a marathon runner, but obviously that's not usually who's coming to the ED. Other causes, though, would be tissue that is not getting well perfused. And that is part of really what happens in sepsis. But the things that I tell providers to think about would be, for example, somebody with mesenteric ischemia, which is one of the classic causes of an elevated lactate. The C in lactate would stand for congenital abnormalities. That's going to be a very rare presentation. But for pediatrics, we can see things like MELAS, which is metabolic encephalopathy with lactic acidosis syndrome. Again, I don't think we're going to see much of that in the adult population. The T would stand for thiamine deficiency, and I actually have seen that as a cause of an elevated lactate, usually occurring in patients who are heavy alcoholics with poor nutritional intake. The next A is for accelerated glycolysis. I've seen that in somebody who's getting aggressive beta agonists, for example, somebody with asthma. Now, you could say that that could also be because of the lung disease, and that is absolutely true, but the beta agonist will probably also elevate that lactate level, so something to keep in mind. The T would be for toxins, or the second T. The classic one is fenformin. We now occasionally blame metformin for that, but studies have shown that metformin is pretty unlikely to do it. So there's really not a lot of toxins that I think are doing it these days. The E, this is not a great one, but it still works for the mnemonic, would be extracellular shift due to alkalosis. So again, just something to keep in mind. If you have somebody who's severely alkalotic, the lactate can go up from that. And then finally, the S is for sepsis. And I really do believe the vast majority of patients who have an elevated lactate probably do have an infection, and certainly you need to be concerned about sepsis with that.
The other piece of that I just mentioned is that an article by Kumar showed that 20% of the sepsis infections, the source may be unknown, and if you do go ahead and get that lactate, at least get you thinking in the track of sepsis and all those underlying tissue issues with a very small 2 to 6% of wounds and even unknown places you might not detect the sepsis on a visual assessment, but then you've got that higher lactate that takes you down that sepsis level, at least as a consideration in case the source is actually not terribly evident.
That is absolutely right, and you are correct. They've even shown that in studies where they've gone back retrospectively and looked at patients who, by the electronic or by health records review, absolutely showed that patient had sepsis. We still get that same number. About 20 to 25% will be culture negative, but at least as part of this initial screening, that elevated lactate may give you some insight to something is going on where we're getting at least relative tissue hypoperfusion. So no, that's a great point. Yep. The next topic I wanted to talk about would be sort of this notorious fluid bolus. And this is, I would think, really out of the CMS bundle, probably one of the parts that I hear the most pushback on. And I will tell you, absolutely, as a nephrologist dealing with patients who have end-stage renal disease, this was one that truly made me the most concerned when I first heard of this bundle and it first came out years ago. So to just give a little bit of a background, the reason we give this fluid bolus is it actually dates back from kind of earlier pediatric literature, I think in the late 90s actually, where they did show that in a pediatric critical care population, those who received an aggressive fluid bolus, and it was in fact the 30 milliliters per kilogram, that showed a significant improvement in mortality. You know, that led to some additional studies in adults, including the RIVER study that I think most people are familiar with. Excuse me. And then more recently, there was 3 randomized controlled trials that were all released simultaneously in the New England Journal of Medicine, the ARISE, the PROMISE, and the PROCESS trial that looked at really early goal-directed therapy, but the fluid bolus being part of it. Now, the interesting thing about those trials was they actually did not show a mortality benefit to their early goal-directed therapy. And some people have looked at that and said, well, see, that means I don't have to give a fluid bolus. If you look carefully, though, that's actually not true because, in fact, the group that was receiving standard of care, not the early goal-directed therapy, but the standard of care at that time, the fluid bolus had been around long enough that the standard of care received a 25 to 30 milliliter per kilogram fluid bolus within those first 3 hours. So even their standard of care group received this. And most people think that's probably why we couldn't delineate a mortality difference between the two groups, is because the standard of care was already receiving an impressive amount of fluid. So at this point, I can say anecdotally, I really have not seen a lot of patients develop pulmonary edema, even when we're dealing with the end-stage renal disease population. So typically, if you really have a patient who meets those requirements for the fluid bolus with persistent hypotension or a lactate greater than 4, my recommendation is still that you proceed with that fluid bolus. Certainly, if you're worried about the patient, if they are end-stage renal or they have severe congestive heart failure, you know, definitely monitoring them very, very closely with frequent vital signs, frequent measurements of the pulse oximetry during the time you're giving the bolus, I think is very appropriate. So I still do believe it is an important part of treating patients with sepsis. I think over time, this will become more patient-specific too, that we will begin using point-of-care ultrasounds to look at IVC compressibility, to look at cardiac function itself, and that I think at some point, we will be able to use more patient-specific. So instead of just saying everyone gets a 30 milliliter per kilogram bolus, we'll be able to say, you know, in certain patients, we believe this is important, but if we're seeing signs of fluid overload, we will be able to tailor that a little bit better. And in fact, I still do. You know, if I have somebody who is beginning to show signs of pulmonary edema, I will stop the bolus, knowing that I've given them as much as I believe they can have. Even if I'm not meeting the CMS bundle on that one patient, I'm willing to accept that. I honestly believe that we should probably not strive for 100% on the CMS bundle, that we still need to do this individualizing it for each patient. Nonetheless, I think the majority probably will still benefit from that. You know, CMS has started to come around some with this too. They are now accepting the, instead of having to use the actual weight, we can use the patient's ideal body weight as long as you make mention of that. So I think that is important. And then there are other things certainly that, you know, if they do have an LVAD device, they will exclude that, but otherwise really no other exclusion criteria. So again, I know a lot of people are hesitant to use it. Again, anecdotally, I can tell you it's very rare. I've really put somebody in pulmonary edema and either had to dialyze or aggressively diurese. What I will say is by the time that patient is getting ready for discharge, however, we need to do a lot better job of paying attention to what their weight is compared to what their weight came in. We need to be getting them back closer to euvolemia before we are discharging them, because that's one of the things that we see is one of the #1 causes of readmission for patients who have had sepsis is they're presenting back with congestive heart failure. So again, if you're having somebody who's 15 kilograms above their dry weight and you're getting close to discharge, you absolutely now need to begin thinking about how am I going to get that fluid back off. So that's my thoughts on the fluid bolus. I still believe it's important, but you got to watch the dry weight before they leave.
Thank you. You brought up a very good point about the high readmission rate with sepsis as well. And I know that you've been drilling down into your readmits to find out what are the causes of those sepsis readmits. So I appreciate you mentioning the CHF piece and also the ideal body weight associated with the fluid bolus that was the new addition from CMS. I think that's very important. And initially, there was more distrust with 30 mils per kilogram, but the ideal body weight took care of a tremendous amount of concern, I think.
Absolutely. And so the last piece that I did want to speak about is really what I would put into the broad category of antibiotic stewardship. You know, as we're using these broad spectrum antibiotics initially to treat sepsis, which is absolutely appropriate, what really needs to be happening in all organizations who are focusing on this is, what do we do after we give them the broad spectrum antibiotics? And really, it is how can we quickly peel those back to narrow spectrum? How can we peel them back to the very specific antibiotics that that patient needs? And so I think whenever organizations are looking at sepsis and trying to figure out how are we going to tackle this, how are we going to improve our outcomes, I really believe they need to simultaneously be revving up an antibiotic stewardship program, because you need to make sure that you're not just putting somebody on broad spectrum antibiotics and leaving them on that. And so we have definitely kind of partnered those two together. And I think the first line in antibiotic stewardship does have to be the admitting provider, because the emergency department is doing exactly what they should do when they are, you know, screening the vast majority for sepsis and often beginning early treatment. But as the admitting provider, your job really is to look at that patient and decide, do I really see a source of infection, or do I have a suspected, you know, source of infection? Because if you can very firmly say this patient is not infected, then they absolutely do not need to be on those antibiotics, and those could be stopped immediately. Saying that, I think most of us aren't terribly comfortable if we can't say with 100% certainty. However, when you get out to that 24 and 48 hours and you have all negative cultures, then it's definitely time to start reeling this back as quickly as you can. You know, there are some additional testing that we've begun using to try to help us with that. We do use the procalcitonin. I'm not sure I feel like it has a strong enough data to say it can help you rule in or rule out sepsis, but it can definitely help you with tapering antibiotics. One of the other things that we've gone to is we are using PCR testing, both for our blood cultures. We also use that for stool cultures, and for, we have a respiratory viral panel that we can look at. And that's very useful, because a lot of times we would have somebody present with, for example, you know, this massive diarrhea, and we've started them on, you know, antibiotics that would be appropriate for that. And then we would suddenly find out there was the norovirus, and we're able to basically get rid of all those antibiotics and just use supportive care only. So, you know, those are some additional tests that may help. You know, certainly we didn't have that even when we started. One of the big things that has helped us is having a pharmacy program that really monitors those cultures in actual real time, because, you know, a lot of times providers aren't pulling up those cultures all the time to keep looking at them, whereas our pharmacists who are out on the floor, they really are continuing to update those cultures almost nonstop, so that as soon as a culture comes positive, or hopefully if the cultures remain negative, they then reach out to the providers, contact them, and we either stop the antibiotics or start tapering rapidly. And they've been doing the same with our PCR testing on the bloodstream. So we will often get that information back within 3 to 6 hours. And if we're able to find that it is not a resistant organism, we can very quickly peel back those broad spectrum coverage. So that really has helped fairly dramatically. The other part of the stewardship program is really looking at decreasing the duration of antibiotics. There's some new data that really suggests we are probably treating with antibiotics way too long, even in the setting of a known infection. You know, for example, an acute cystitis really probably needs no more than 3 days of antibiotics. You know, if you have somebody with a pneumonia and it's an uncomplicated, 5 days is probably sufficient. And there was recent data that looked at actually gram-negative rod bacteremia, and in uncomplicated cases, those patients may need no more than a week of therapy. Now, there certainly are other infections, such as MRSA in the bloodstream, that is going to need, you know, prolonged therapy, 2 weeks, 4 weeks, 6 weeks, depending on, you know, what the source is and what the involvement is. But certainly, you know, looking very carefully at how long we're using antibiotics is going to be important, again, to help prevent resistance and to prevent overuse of antibiotics.
Thank you. That's a very, very important topic, and we've had a lot of work groups within the state of Indiana working on antimicrobial stewardship. What some people forget is that the Kumar article that talked about 8% increase in mortality for every hour delay in antibiotics was actually talking about a delay in effective antibiotics. So it circled back to the culture, and so if you don't get the right antibiotics in a timely manner and with the culture, then you are increasing mortality by 8% for every hour that you delay. So that pull-in of the pharmacy and real-time monitoring of that is extremely important for mortality. So thank you for bringing that up as well. You brought up some interesting, significant points that I know you've run into as you've done fine line review of every case. That this is the bundle in your hospital, so you know what the questions of the physicians are in the process and some of the dialogue that they've had around screening efforts and casting a broad net, and do give the 30 mils per kilogram of ideal body weight. What we've also seen is that efficient treatment can have a shorter length of stay as well as decrease the length of stay in the ICU, which can prevent post-ICU psychosis to some extent, along with other measures. But everything, we don't think it's not just mortality it's affecting, it's also quality of life of early treatment of the sepsis patient and effective treatment with the sepsis bundles and antimicrobial stewardship along the way. So also, one other thing we thought we'd talk about just very briefly is clinical documentation integrity and the value of the interaction between the CDI clinical documentation integrity team and the physicians for accurate documentation towards an appropriate diagnosis. Any comments on CDI involvement?
Yeah, absolutely. Thank you for bringing that up. We actually do have a very robust clinical documentation department here, and they have actually reached out to the providers, typically going to section meetings, to really describe, what their queries are about, what they are asking us to do, and what they're not asking us to do. And I think initially they started sending queries about, well, do you think this patient had sepsis or not? And I think the providers initially thought they were almost pressuring them into calling that sepsis, and that absolutely is not what they were doing. Really what they wanted, again, us to do as the admitting providers is to kind of take a step back, knowing that, we have encouraged our emergency department to, again, cast the broad net, treat very aggressively any of those who might. But then what we want our admitting providers to do is to take a step back and really look at that patient's course and say, okay, based now, basically retrospectively at the end of the hospital course on everything that I know, do I truly believe that patient had sepsis or not? And if they had sepsis, yes, absolutely document that. Document to the level of specificity that you can, including the source, including the severity of it. But at the same time, if you really believe that they had a different disease process that explained those symptoms and you're not seeing any sign of infection, then we absolutely want to document that correctly too. So again, I think, in organizations that are just really starting to tackle sepsis, that are trying to roll this out, making sure that documentation piece is included is going to be really paramount, because you can screen for it, you can even try to treat it, but if you never document it, in truth, you're not going to get credit for the improvements that you will be making, because that's really been one way that has helped us really look at what our mortality is through that documentation. Because if we're accurately capturing those diagnoses, at the time of discharge, we can go back and really then look into our mortality. And we have definitely been able to show significant improvements in mortality benefit because we have been able to accurately document that.
Excellent. And also within the documentation process, there's unspecified sepsis, and then there's all the sepsis specified by the organism that's growing, which I know CMS would like to see us definitely use those specific 20 or so diagnostic categories that include the organism instead of just coding it as unspecified sepsis every time we can, so that they can actually see what's causing the sepsis out there and do some performance improvement. We each can at our hospitals over the actual organisms we're seeing associated with the longer lengths of stay or whatever specific demographics of the patients that may be comorbidities that may be driven by that organism.
I was just going to say that's absolutely correct, because again, once you're sort of tackling sepsis a little bit better, what you really want to know is, are we having problems with specific organisms? Do we have a lot of MRSA that we need to be tackling? Are we seeing a lot of Clostridium difficile? So it really does help you pare that down then, as far as, okay, we're screening, we're treating, but now what are we going to do about prevention? And so I think that's one of the key points in making sure that you're accurately coding. It will help you then to turn around and drive that prevention piece that we all need to be working on also.
Using our artificial intelligence to do so in every opportunity as opposed to having to create our own queries.
Absolutely.
All right. Well, thank you very much, Dr. Kiser. I appreciate your attention to the detail for your patients' benefit, as well as Columbus Regionals and your leadership in the state. Thank you so much for your podcast today.
You're very welcome.